I haven't been around for a while. I've been on rotations, but let me give a brief update real quick about the clinical trial with the Nivo IPI for the salivary gland and ACC patients. Can you see my screen?
Yes.
Okay.
Well, not yet. Not yet.
Oh no.
Drop
Um,
by.
huh, okay. Uh, okay, now can you see it?
Yeah.
Okay, great. So we've been waiting for Luna to get back with the Lunit Scope AI reading of the pathology slides for the patients that we had tissue samples for. Um, so we got it back, and this is the data that we got from them. So we had 6 patients who had tissue available. Um, 4 were classified as immune desert, 1 immune inflamed, and 1 immune excluded based on their inflamed scores. And then I included in the table their PDL1 expression as well, their ACC status, and the best response that they had. So this is the data that we have for it. And then I I made a slight error. The patient who had a positive response, there was one patient. Um, we don't have their tissue, but I can get their tissue. They're at the University of Chicago, and so I'm sorry, but I can get their tissue and have it like contact them, get it shipped here, or like go pick it up if needed. And then once that's done, um, hopefully it shouldn't take long. But this is
What was the Oregon? What was? Remember, do we have to contact one in at West Coast? Which one was
yeah,
that?
Oregon was one of the stable disease.
Oh, okay.
Actually the zero. Yeah, but yeah, I double checked everything at the end and I was like, oh shoot, I the positive responder is not here. So sorry about that, but I will get that one as well. And then um in the manuscript itself, this is a paragraph that I wrote describing um the Lunit results.
Can you magnify it a little?
Yeah, here.
Yeah, this is a little counterintuitive, right?
Yeah, it's like the exact opposite of what to expect.
And these were patients who were treated with what?
Nivolumab and ipilimumab.
Yeah. So maybe you can make an argument that ipilimumab is the one that brings lymphocyte from outside. Because I think PD-1 or PD-1 plus some other targeted agents require something. You need something in the microenvironment. Versus IPI, you people argue that even in immune deserts, IPI's role is to bring lymphocytes from the nearby lymph nodes. So you can find some articles advocating for that. So you can speculate because of the IPI regimen that you could see stable disease even in all like immune desert population. You can make that kind of argument based on those publications.
Huh, okay.
But let's see what the PR, right? PR
Yeah.
HCM side looks like. I mean, it's going to be better. I mean, the more cells you have, it's going to be better. However, Yippee can do magic. That's what people
Hmm.
say.
Okay. Yeah, you mentioned that before actually. Well, not exactly that, but about like the magic of ipilimumab. What I was looking for was a citation, an article, because before you mentioned that like ipilimumab can help to extend the responses that patients have to immune checkpoint therapy, like extend the amount of time before progression of disease, extend the amount of time in stable disease. Do, do you know a good citation for that, like a good article to refer to or to
Oh
cite?
yeah. So in lung cancer field, it's the Checkmate 227 trial that showed durability of nivo-ipi regimen in non-small cell lung cancer, chemo-sparing approach. And
Yeah,
then there is 9LA. It's just the upfront 2 cycles of chemotherapy followed by nivo-ipi as a maintenance. So
yeah,
that also rendered very good durable response, even compared to Keytruda combo, which doesn't have CTLA-4 components. So I do think it speaks to its durability. And there's
yeah.
another CTLA-4 inhibitor, which is called trametinib. The trametinib is only approved in hepatocellular carcinoma and non-small cell lung cancer. The non-small cell lung cancer trial is called Poseidon. Poseidon. You can find that trial Poseidon as in Greek. Yes. Um, and that trial also showed durability. Um, so maybe you can kind of use that as a real world proof.
Okay. Checkmate 2279, LA, and Poseidon trial. Okay, I'll look into those three. Okay, great. Thank you. And then
No, no problem.
I can show you
And
the
and and then there's like melanoma Nivo EP trial that showed great durability as well
okay,
compared to Keytruda alone. So your comparison is really the PDL1 alone. You
okay.
know what does addition of CTLA-4 do? You can find really good review articles on that as well. Yeah.
Okay, great. Thank you. And then uh yeah, this is I wasn't really sure how to interpret the findings, but I can change this part. This is in the result, the discussion section, but I can change it once we get the last positive responder
Right,
histology and then
right. But I mean, it's true. It's not um, in line with previous literature.
yeah.
And you can cite that. What literature are we talking about? Like the pill corresponds to better response. That
Hmm.
type, but even the Lunitz paper, they don't usually distinguish CTLA-4 combo. It's mostly PD-1 monotherapy.
Mm,
Their articles. So you can argue that most previous art literature talks about only PD-1 monotherapy, uh, as opposed to ours being um, strictly CTLA-4 combo.
I see.
So that makes difference, and that might you know so you know pill may not be uh, 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 as strongly associated with response as in the case of PD-1 monotherapy. So you can make that kind of argument.
I see. I see. Okay, not
Yeah.
entirely comparable. Okay. And then one last thing. Um, so they mentioned different cutoffs for Lunit, where in some papers they have like a 25% cutoff. Some papers have a 30% cutoff for immune inflamed based on the tumor microenvironment. Is ACC a cold tumor? They mentioned for cold tumors, 25% could be like you could have a lower cutoff of 25% of inflamed score to
Yeah,
classify.
it's generally considered cold tumor. So I
Okay.
think that makes sense.
Okay, cool. Just checking. Okay, that's all the questions I had then. Okay, great. Thank you.
Very good.
I'll get
You're
the
almost you're almost
yeah.
there.
Sorry. Yeah. I will get I'll finish as soon as I can. Hopefully by November. I'll try.
Okay. Yeah, and then just adding this translational component.
Yeah.
I think if you get well, I think you can shoot for AACR. Even with what you have, like the 6 patient it's a
Mhm.
translational medicine piece. You can add this and um did what was the previous meeting that you presented this week? Or you haven't?
I presented at AACR.
Last year, right? So you
This
can.
yeah.
Oh yeah, that meaning this year. Yeah, this year, right? Yeah. Next year, I mean, what just the translational part is something you added, so I think you can add the translational piece, um, and then present that at the ACR again.
Oh,
Um,
okay, yeah.
yeah, it's a translational part, and it's only 6 patients, but I think it makes sense.
Yeah. I can aim for it, yeah. And we have other translational stuff too with the RNA sequencing, DNA sequencing, and the genes that we found. Some of them are interesting, so we can try with that.
Yeah. So why don't you make an abstract based on that? And deadline's coming. When is it, Leon?
The AACR deadline is November 16.
Okay.
So I
Uh,
think it's doable.
okay. And I can try
Yeah,
to, yeah. Hopefully we can
yeah,
get
yeah, yeah,
other
yeah.
responder too by then. I can try.
Yeah, if you,
Yeah.
yeah, because like PR is missing is kind of, it's just SD and PD. So
Yeah.
okay,
Okay. Sounds like a plan.
sounds good.
Thanks.
Thank you. Oh, actually, Lisa is here. Good morning. Do you have any
Okay.
update for us?
Yeah, I just got a couple questions for our very straight paper.
Okay.
So I think we're like almost like 90% done with the paper. But I couldn't come to the last week's lab meeting. So I just wanted to clarify a couple stuff that Tiggy already discussed with you last week. So I don't know if you had a chance to go over all the tables and figures that we prepared.
Whatever he presented, I went through, but nothing afterwards.
Okay. So anyway, the introduction part pretty much done, but we do have to add some more detail on this. And then the method part, we made this figure. So basically, we could not like describe it in like ideal way, like from non-small cell lung cancer patients treated from this time frame in Northwestern Memorial Hospital. Like we don't have that like consecutive patient cohort for non-small cell lung cancer treated with immunotherapy. So basically, we started from the very strat list, and then we sorted out patients who had non-small cell lung cancer and immunotherapy. So we just
But
started.
but isn't that consecutive? Because we got everyone who ordered very straight.
Yeah, so actually, like our original plan was we got the consecutive patient list who got the very strat tested from this time frame, and then among them, non-small cell lung cancer was this. But I heard from previous meeting, it makes more sense to start from like this many patients were having like non-small cell lung cancer and got very strat tested, and then like among them we included this. So just want to clarify that. Because I heard in previous meeting, we got a comment from you that like getting very strat tested might already be like a biased patient cohort. So so yeah, like initially, like how we generated this list was we got like 400-ish list from Jackie. And then we removed a certain amount of patient who had indeterminate result. And then among them, we sorted out those patients who had non-small cell lung cancer. And then we sorted out patients who had immunotherapy with non-small cell lung cancer, which gave us like 174 patient list. And then among them, like, so of those 174 we added for the toxicity analysis, and then we removed patient who got the immunotherapy not for palliative purpose. And then And then the final cohort for the survival analysis was 158. So that's actually how we got the result. So we were just kind of trying to find the best way to describe the process.
I'm sorry, I got cut off. I think for like 1 minute.
Oh, so the bottom line is like, should we start it from like among non-small cell lung cancer patients treated from this time frame in Northwestern Hospital with available very straight test result. That's how we actually started the description. But like, would you prefer the other way that we originally thought of, like among these like consecutive patient list who had very straight tested from this time frame, like non-small cell lung cancer patient were like this much, and then like among them like this much had the immunotherapy.
I think this is okay because I feel like very fair unavailable patient is too many
Okay.
compared to the baseline. And I
Okay.
think the reviewers will ask like, why is there such a big discrepancy? You know, it's a provider preference. So I don't think it will look good. So I think I'm fine with this.
Okay. So we'll just keep it this way. And then the method part we describe this retrospective cohort, and then we set the regimen of interest, the closest immunotherapy regimen from the blood draw. So
Yeah, but in the method, you can still say it's a consecutive patients treated in this period who had their result available. So
okay.
you can still use consecutive.
Okay. And then that's it. And then for the result part, we have the baseline characteristics table. So as we discussed before, we have two demographic tables for the survival analysis and then the toxicity analysis.
Those are two different groups. Yeah.
Sorry?
Yeah. It's okay to have three different groups.
Yeah. So these are the patients added for survival analysis who got the immunotherapy just for palliative purpose. Total of 158 patients, and then this is patient included for toxicity analysis, who got the immunotherapy for whatever purpose, including adjuvant and neoadjuvant. Total of 173 patients.
Are you able to put those side by side and make it one table? Is it too big?
I mean, it's possible. Like, do you want me to make this like columns like narrower and then like put everything in the same
You
page?
can do the landscape other as opposed to portrait.
Ah, so you want it to be like a landscape and then like 6 columns.
Wider
Like,
table. Yeah.
okay.
Yeah. Some journals do that. And because it's too much to use two tables for just demographics.
Okay. So that's the demographics table. And then after describing the demographics, we go straight into the survival analysis with the forest plot by very straight classification, and then multivariate analysis, and then those survival table. So with these survival figures, our plan is just make it smaller and then just put all those 10 survival curves in the same page.
Yeah.
So about this forest plot, like none of the group, I mean, like couple, maybe some have some like statistical non-significance because the CI actually crossed this 1.0 line, but like most of them have like hazard ratio over 1. But actually my biggest question for this was I just put this like x-axis as like a hazard ratio 95% CI, very straight poor over good. would you want it to be like good over poor, like to show how good shows like better prognosis? I put it this
Oh,
way. Because I put it this way because down the road, when we describe the toxicity part, we say like poor group develops like severe high grade toxicity earlier than good group, and then we give hazard ratio poor over good. So I just wanted to make it like consistent. But other papers, like comparing these like very straight good versus poor, like most of other papers do like good over poor to show like how good very straight good group has like better prognosis. So I'm just wondering how you think about it.
so what is the percentage between the two?
Good versus poor. Good is 131 and then poor is 42. For survival analysis, like 74 and then 25.
So just statistically speaking, not clinically, it's good to have reference with the more numbers.
Mhm.
So if you have reference as good, then four, is a poor risk factor, right? Poor risk is a poor risk factor. So I think it's okay to leave it at this. And
Okay.
if the reviewers have problem, then we can change it later.
Okay. Sounds good. So
Also check with Biodesix because their product, so they should be okay with it too.
okay.
Yeah, just kind of sidebar. We did this analysis. Like, want to make sure you guys are okay with this.
Okay. Okay. So for this first plot, like the overall population, there was like statistical significance of a very strict poor group having worse survival outcome. And then for IO monotherapy, it was statistically significant. And then chemo IO combination, like CI interval was slightly over the borderline. But this was pretty consistent with what they have presented with the INSIGHT trial.
Yeah, so that should be all in the discussion, and because it's but we don't have chemotherapy alone. We never even looked at it, and no one
No,
does it recently. So, um, well, I guess, are you gonna show the insight trial or?
I mean, I think Wonbin did chemo only survival analysis.
Oh yeah, one bin did it. Yeah,
Yeah, and then about chemo, I think they have already done it like many years ago.
right.
Um, let me see. Oh, I don't have Wonbin's paper open. Oh yeah. So Wonbin did chemo only and IO only.
Mhm.
And then for Wonbin's paper, OS for chemo was statistically significant.
Mhm.
So I mean, I can look up like more data regarding like chemo only, but my understanding after reading about this was like it did have like prognostic and predictive value for chemotherapy.
Mhm.
So I think it'll be nice if we could give some explanation why we're not seeing like the same effect when it's IO and chemo combined.
So Veritrat was supposed to be prognostic for chemo only as well.
Yeah.
And immuno only, they made immunostrat, but Veritrat is supposed to be predictive as well. But I think what we've been trying to show is chemo immuno combo is also prognostic. So I think I think the logic is, it although it's borderline, it does seem to be um prognostic or I think predictive of benefit is
Mm,
better word than prognostic.
okay. Um, okay, so this is multivariate analysis table. Veristrat has the most significant value here. And then other significant factors were ECOG,
Where's the mono variant?
here, the regimen versus ICI combination, ICI monotherapy had worse.
No, I'm saying the univariate.
Univariate. Oh, we did not do that, but should we do that? Because the JITC paper, they only added like the multivariate only, but we could do that.
Yeah, I mean it's okay to add just multivariate, but I think either in supplemental or as part of the big table, people like to use some table three can be univariate and multivariate, meaning you have a unadjusted HR and then you have adjusted HR in one table. That that makes it, and then p-value for each.
Sure. We can do that in like one table, like univariate and multivariate.
Yeah. Here's with that.
And then, so this is the survival analysis part by the regimen. So the figure 1 for the survival analysis will be survival analysis by regimen type. And then figure 2 for survival analysis will be the analysis by the PDL1 level. So I think Taegu went over this with you already. So so these are just very stretch, good and poor, like good having better survival outcome for PFS and OS, for overall ICI only, and then combination, and then first line, and then second line. So regardless of the line of the treatment, you still had.
Yeah, looks good.
And then this is probably what we discussed with you last time. So we had this like PDL1 over 50 and PDL1 under 50, PDL1 under 1%, and then intermediate, and then PDL1 over 50 with ICI only. So I think those are all, like we are on this all on the same page, that these are added to the major figure, and then we are done with like describing this on the result section. I think our biggest question last time was you wanted to do more analysis for this PDL1 over 50 group. But like we were wondering, because like PDL1 over 50 groups already like 35 patients, which is not many. So like doing the subgroup analysis was like not like really feasible.
So what was my comment? I don't remember what I said.
So actually, I heard from Taegu, so like I don't know like what exactly you said, to be honest. But I heard that like PDL1 over 50 and then IO only group is the group that people might be most interested in. So it might be helpful to add like subgroup analysis for PDL1 over 50 and IO only group. But like that makes like really small like total number of patients.
So this is IO containing therapy, right?
Yes. ICI only and then combination. And then it gives us a total of 35 patients.
Okay, two comments. So my expectation is that you listen to my comments. That's the reason why I record. I don't want to have you listen from secondhand from Dr. Peggy. That's the only reason why we're recording this, so that people who does the project listen to it in their free time. Okay. I want to make sure you listen to it. Okay. Okay. Number two, people are going to ask, because the greatest clinical question is that in people who only receive immunotherapy, um, in PD-L1 high patients, is that enough? The monotherapy, chemo-sparing approach. So they are going to ask no matter what the patient number is. So it would be good to have a supplemental figure. And it might be just because of the very small sample size, it's not going to show anything. It's okay. We say it didn't show anything.
Okay.
So, so I think even from the inside paper, that was the main idea, that even in PD-L1 50, do not use monotherapy, because PD-L1 very straight poor group will still do poorly. That was the main point, right?
Yeah, that's what they presented in the Word Long this year. This is over 50. I think in their manuscript on the JITC, I don't think they did that subgroup analysis. But they added to the poster recently. Yeah, but you're right.
Yeah, so it might be 10 to, I don't know, but in PD-1 high, clinically, we like to use just a monotherapy unless there is a clinical pressing need, which is very symptomatic disease, huge tumor. In that case, we do use combo. So I think the reviewer is going to ask that question. So we would have to give out the number table, or the figure in at least supplemental. And now I don't, and then depending on what our graph shows, we can say it is in line with what Insight study showed, or maybe we can say because of the small sample size, hard to make any conclusions.
Okay.
But the whole point is very straightforward. PD-L1 high, let's use combo over mono. That is the biggest clinical point. And I
Yeah.
don't know if we can make that point with our study. We might not, but that is the most important point from Verisure.
Okay. So do you want us to?
And I did say for those one, because this is not a randomized study, this is not a prospective study. There's got to be a reason why in PD-L1 high patients, the preferred regimen is chemo-sparing approach. If they got chemo-immuno combo approach, what was the reason? And I think last meeting I said, let's figure out, because some reviewers might ask, like PD-L1 high, usually we give monotherapy. Was there a reason why combo was used? So that was my main discussion last time.
Oh, okay.
Maybe that wasn't conveyed to you from Taegu?
Actually, my understanding was for PDL under 50 group who got immunotherapy only, we need to figure out why they got IO only regimen.
So that's even a bigger question they will have. Yes, I did mention that.
Yeah. So about that, like our plan was just to go through the every patient, like which is about like 40-ish patients, go through all the Epic chart and then like figure out why those patients got the IO mono.
Yes.
So I think that's the plan that we're gonna proceed with, but we did take a look at the chart that we collected, the raw data that we collected, and then see if they were on like any clinical trial or their ECOG like performance status was worse. But like on our raw data, we did not see anything like super biased. Like all these regimens were mostly ipi-nivo. And then most of them were stage 4, and then performance status was like most of them were just 1 or 2. So I think we should just go into each and every patient's chart and then see like how the decision was made. But according to the raw data that we collected, like we didn't see like obvious the bias on the data.
Yeah, I think that's important
Yeah.
to describe. And now I come to think of it, this is not our proof because I'm the only one who uses VeriStrat. So this is based on my own clinical judgment. And my assessment of the data is that for the nivo-ipi combination approach, the data does say that even in PD-L1 low or negative, the nivo-ipi data is pretty good. Although the FDA official approval is only for PD-L1 positive, I do not like to use nivo-ipi for less than 1% as well. This is kind of off-label. But anyway, I also think 9LA is a semi-chemo-sparing approach because you don't give any chemo more than 2 cycles. It's very small.
Yeah.
So it's say because I use a lot of 9LA regimen in PD-L1 I guess high risk patients as well. And my rationale is to avoid hyperprogression. The only reason you add 2 cycles of chemo is to avoid hyperprogression, which can happen 5 to 10% non-small cell lung cancer. So I guess that is the reason why PD-L1 high, there's such a there's more, let's say, more chemo immuno combo than average. Yeah, it's gonna be tough to describe all this rationale because it's way beyond the scope of this paper, but it makes sense to describe that you look into the reason why combo was used for PD-L1 high and why mono was used for PD-L1 low, and describe there seems to be no differences in obvious clinical pathologic factors such as performance status or whether there is a symptomatic disease, whether patient required chemo-sparing approach due to comorbidities, and many others. Yeah, but it's important to say you looked into it and you didn't find much difference, and I think the reviewers would be interested in knowing ICI mono versus ICI chemo combo. What was the percentage of the immunotherapy drug? Pembro versus nivo-ipi.
Yeah.
Because nivo-ipi and pembro may have different outcome. So I'm sure you guys collected the drug names.
We did.
Yeah. So I understand it's going to be subgroup analysis, and it's not going to yield any statistically meaningful benefit. But regardless, that's why we have supplemental. I think it's worth um looking into the difference between the two, and um you can say the immuno-only regimens were mostly nivo-ipi, or something, like the regimen might explain
Okay.
why immunomono was used and PD-L1 negatives, things like that.
Okay. So yeah, I think that was a major question that we had. And then so about this supplementary figure, or we'll just hold on, like we'll just hold off like putting it on our tables. We'll just try to look into like each and every patient who got those treatment and then see if it was biased or not. And then discuss with you again.
Okay.
So those are the analysis that we did with PD-L1 under 50 and IO only, and then PD-L1 under 50 and very such good and IO only versus chemo IO combination, because we thought like some subgroup analysis might be possible with this PD-L1 under 50 group, because we have like 100 patients for PD-L1 under 50. For PD-L1 over 50, we only had 35.
So yeah, and this was the abstract you presented, right?
No, the abstract, did you say?
Yeah, didn't Biodexis wanted PD-L1 less than 50 at one time?
So that was for survival analysis. So for survival analysis, we presented as a poster for PD-L1 under 50 and PD-L1 negative. That was like over like the PEN regimen, but we did not do the subgroup analysis back then. And then this time we did the subgroup analysis of PD-L1 under 50 with IO only. And then, so when we discussed this last time, we figured that like we might need to take a deeper look into this, like to figure out like why each patient, like this 44 patients got the IO only regimen when they have PD-L1 under 50.
So here is IO only, and it seems to be pretty significant difference there. And then this is IO only. So yeah, I think it makes sense. But this is why I gave that comment last time.
Yeah.
If anyone looks at this graph, like why are you not giving? Why are you giving mono in this population? And I'm thinking most of them could be nivo-ipi, not. I don't think there's any pembro here.
Yeah,
You
so that's
understand?
what we discussed with me and Taekyu and Alan. We looked into the raw data that we collected last time. So that's we figured out like there were ipi-nivo mostly, and then most of them like performance status was like 0 to 2. Let me see if I still have that. I think I made the separate Excel file for that patient population, but I can't find it right now. But I think we'll just go through the every like 44 patients in this patient population, and then I'll make a separate table by next meeting, so you can like take a look into it.
Okay. Yeah. So I think this is important because even addition of CTLA-4, if there is risk 4, they're gonna do for, if you look at the CheckMate 227 data, the PD-L1 low and PD-L1 negative data is still pretty good, but the comparison was chemotherapy.
Mhm.
But you can see here in our data that Nivo, if you in a PD-L1 negative patient, the literature for the EP did not help at all. So this is probably a first data where majority of patients, and maybe none of them is Pembro. I don't know because I don't use Pembro monotherapy for PD-L1.
We'll take a look.
Yeah, so if this is 100% Nivo EP data, this is probably the first Nivo EP data created in the PD-L1 low setting with comparing very strength for and good. So you can highlight or emphasize that even you can argue that it's a combo immunotherapy, that addition of the ipilimumab really does not help overcome any negative impact of the VEGF one.
Mhm.
So that might be something that is novel about the study.
Okay.
That PD-L1 negative and PD-L1 low, I used a lot of Nivo-Ipi, but first poor is still poor prognosis factor. Not just Pembro with Pembro, but with Nivo-Ipi as well. So
Okay.
you can make that a point by doing that in-depth, analysis.
Yeah, or if there's like other patient, we could do another analysis, which is ipi-nivo patients only.
Yes, and Ipi-Nivo, because I use so many. So one suggestion, the more I think about it, because I use 227
Mhm.
and I use 9LA. So you can kind of group them by regimen. And no one has done that before. Because so many people across the nation uses keynote regimens like carbopen pembro, right? So like have you seen U of C or Georgetown uh doctors using 9LA and 227 like I do?
And ipi-nivo only.
Or 9LA, which is 2 cycles of chemo.
I've seen that. I've seen that 2 cycles of chemo followed by immunotherapy. I've seen that happening. And ipi-nivo I've seen like regardless of the PD-L1 level, rather than starting chemo IO combination, they started like ipi-nivo. They said I heard like pembrolizumab or something for carbopen pembro, like one of the drug was like shortage in like nationally. So they started like ipi-nivo right away, and then they told me about like the trial that showed like ipi-nivo was non-inferior to the chemo-immune combination, and one of the drug in the regimen is like in shortage, so they like to order it.
So that's a special circumstance. But
But 2 cycles of
nationally, carbo. So the platinum is in national shortage. So that's a tragedy for a lot of cancer patients. But but the thing is, the 90% nationwide people use the Keytruda regimen rather than Nivo-Ipi regimen.
I thought it was interesting because like when we were attending the ASCO conference this year, they did like similar trial with osimertinib, like 2 cycles of chemo first and then followed by EGFR TKI, and then it didn't really work. But that looks like for immunotherapy it was not the case. I was like wondering like what's the difference? And then I kind of asked the attending, but I didn't really get like good explanation for that. So I didn't really think of the hyperprogression part of that. So that's actually really interesting to know.
Yeah, I mean that's why I've been studying hyperprogression. You've been in my lab for a long time, and that was the reason. Like every time we do immunotherapy only trial, if you look at the PFS graph, it always crossovers.
Mhm.
The reason is without chemo, immunotherapy causes hyperprogression in at least 5% of patients. And that is the Minjung's meta-analysis for hyperprogression. And the reason, the only way to prevent that from happening is giving chemotherapy.
Yeah.
And well, that's what I've been saying for the past several years, and not many people believe in it. So that's why it's so hard. Anyway, I think what I'm alluding to is let's do regimen by regimen analysis. So I'm not a fan of the Keytruda combo, but I use it as a standard of care for some people. But I like to use 9LA and 227. So by each regimen, let's see, how very strat do. Maybe by each regimen, it does a little bit different things.
Yeah.
Okay, this is good. This is good that we can brainstorm like this.
So we'll add that additional analysis to our paper, and then I'll come back next week then.
Okay. So like I said, the PDA1 low is one group, but people will still be interested in what happened to PDA1 negative, what happened to PDA1 high, and immunomono versus immunochemo combined. And like I said, I understand the numbers are gonna be low, but still generate them, and we'll select what to include, what not to include. If the figure looks awful, then we can just say we did it and then it didn't show any such like meaningful difference. But saying it and versus not saying it, we haven't done it, makes a big difference because they're going to ask us to do it.
Sounds good. I actually have to head out for work. But thank you for your advice.
No problem. And please follow up on the mass spec data because I know we're waiting for that from Biodesys.
Yeah. But didn't they talk about like whatever legal thing like to be signed? The
Yeah.
paper.
So I don't know. Just follow up on where they
Okay.
are.
All right.
All right. Thank you. Okay. Let's do Eileen. Give us update.
Yeah, so me and Emma have been working on the variant stuff still, and we finished finished collecting data last week or this past week, and we're still on the process of doing a literature search to see like whether we should find a new tool to replace Condel, which is the tool that wasn't working anymore, or if we should just eliminate it. So that's one update, and then also we had a question. So we realized that so for some of the variants, for example, on polyphen and align GVGD, so basically when the original amino acid sequence doesn't match the sequence that's in the FASTA file that you input when you're running it through the tools, basically it like doesn't match, so it doesn't run either, so it like leads to an error. So like sorry, I don't know how to just oh wait, there was one example. So one example is BRCA1 and then the
Do you want to share your screen and maybe explain?
Yes, one second.
So for those of you who doesn't know this project, we're trying to see whether each variance in a given mutation is functional or not. And there are in silico algorithms to determine that. So she's looking at those platforms, how they perform, what are the concordance between different platforms.
Okay, I think you see everything now. Okay, so this was the question, but so for example, BRCA1 K1664E. So in the FASTA file, the position 1664 matches to L rather than K. And then, but in, yeah, and then we have another variant, for example, that does L1664 and P, and that matches the initial amino acid, so it is able to work. But for the six specific example, it doesn't run, but it does run on Mutation Taster, CAD, and Revel, and that's because it only takes in the chromosomal coordinates rather than the actual like amino acid chain. So we were wondering like how we should deal with these variants, like whether we should just take them out or keep them. And also we don't really know why this is happening.
Chromosomal coordinate. I actually don't understand what say why act instead of end message. Hmm.
And there's also not too many of these errors that are occurring though, so
Hmm. Hmm. Well, I guess the whole point is looking at the concordance. So if so in the method you can say if it if it's not able to run in all three platforms, all this number of platforms we included, then we can just say. I think it's if it's just how many of them you were thinking, y'all?
so we don't know the exact number, but like a couple that we highlighted in red, like these, for example. Yeah, not too many, less than 10, I believe.
Okay, then let's just exclude them.
Exclude them. Okay. And then yeah, so that's the data collection stuff that's done now then. Once we take these out, and then now we just have to do the analysis aspect of it. Those are all my updates for now.
Okay.
Thank
So
you. Oh.
yeah. So what is the timeline? Like how close are you to the finish line?
So I'm gonna text Emma again right now after I'm done with this, and then we're gonna figure that out. And then also regarding Grace Lee's project that we were also trying to do, I was hoping to set up a meeting with Amy Cho and Irene. I think Dr. Liam also mentioned that they should be involved with that one. So we'll get working on that one.
Okay, sounds good.
Yep.
Okay, Taeyong, do you have any updates?
I do, and I do have a couple of questions, and I'm wondering what your available time for the meeting is.
Yeah, I want to finish in next 10 to 15 minutes.
Okay, so I do have a couple of data that I want you to look at, so kind of specifically. Should I do that afterwards? Just give a brief update for now. Would that be better?
A brief update and burning questions. Okay.
Okay. So brief update. I've been communicating with Dr. Jian and Dr. Taegyu recently a lot because Dr. Taegyu is now in the army since 9 hours ago, and I received data from him. And regarding the last feedback that I got from Dr. Che, can you see my screen? Yeah, so from what I understood, this table is the big picture that Dr. Che has told the clinical data and radiomics team. But for now, for the AACR 2024, this part is submitted. And I did receive some data regarding the 205 patients from Dr. Taegyu, but for now, this is what Dr. Taegyu sent me in for final. So this is the number of just plain RECIST criteria categorized people for intrathoracic and systematic, and intrathoracic IRSist and systematic IRSist. So this is what Dr. Taegyu has given me, and he so to I guess for until while I'm here, it would kind of be hard for me to finish all the table that Dr. Che has presented, but I guess I'm trying my best to figure out how I should understand all this Excel and see how far I can go until I leave. And one of the parts that I've been digging with Dr. Taekyu is durable response for now. So I do have a lot of patients in specifically to that I want to ask Dr. Che about, but I guess maybe I should do as far as I can for now. Would that be okay?
Okay.
Okay. So for instance, while we talk about durable response, the definition is that any patient who has non-PD for at least 24 weeks is considered durable responder. But if the patient had SD and it did not last 24 weeks, from what I recall from you, Dr. Che, is that you don't consider that as durable response. So looking at the examples, so this is the 24-week criterion regarding the indus treatment. And this patient had SD until like the day before of 24 weeks. Should I still consider this as non-responder? Your mic is not on, Dr. J.
24 week plus minus 1 week is all, okay.
Oh, okay. So plus minus 1 week is fine. So this also regards SD, right? So
Yeah.
okay, so this person would be the responder. And this person is also SD. This person. Someone like, yeah, for example, this person, the 24-week date is September 5th, and this person had PD on September 7th, so this person would be non-responder. Am I right?
So PD was later than 24 weeks, right?
Yes. 2 days later.
So, but was patient SD until that day?
Um,
Because everybody will, not everybody, but most people will eventually go to PD. It doesn't mean they belong to PD group. So you need to have SD remain for the at least 24 weeks, and the PD happens afterwards. They're not, they are still in the SD category.
so would you consider this person as a durable responder?
So initial response was SD, and PD happened after 24 weeks, correct?
Yes.
So that's PD, SD, durable SD.
Oh, but like when I was talking with Dr. Taegyu and Dr. Jian, for instance, this person is SD on June 30th. And if PD was confirmed in September, we would consider that progression was happening since June from September. But I guess we would just think the period of PD starts from this date and so on.
So that's 6 months, not 6 months, 3 months.
These interims are you referring
Oh,
to?
you mean from the start is March.
Yeah.
I see. No, I see your question. It's 6 months from, but it's PD on the next scan. I see what you. So, I think immediate next. So it's due, I think it's the due scan at 6 month mark, right? And that is PD.
Mhm.
So that's PD. Because
Okay,
it's the 6 month. It's approximately 6 month mark scan.
okay. So, to be clear, if PD is confirmed, like the day that's similar to the durable date, 24 weeks, we would still consider it as non-responder.
Yeah, plus minus 1 week. Maybe it could be 2 weeks, plus minus 2 weeks. Around that time, there's a scan that confirms PD, then it's PD.
Mm. So this one was SD until October, and the 24-week mark is December. And on January, it was confirmed to be PD. So I wasn't sure. It's not within the 2-week margin either, so.
Yeah, so I think we just have to have our own internal
Mhm.
um timeline, and let's make that plus minus 2 weeks. So it's out of 2 week window, so
Mhm.
it doesn't count that.
So it wouldn't count as,
PD. It's still SD.
oh, okay. So it's
Because 24 weeks plus minus 2 weeks, within that window, do we have PD? No.
we don't have PD.
So it happened after that window.
Oh, okay, got it. And this one. So would you consider this one as a durable response too? Because this date is like 5 months before the durable day counter. And it was PR, but then after 5 months, it was PD.
Yeah, so maybe it's oxymoron. Let's say you have a PR first scan,
Mhm.
second scan is PD. You can have that. Maybe we'll take out the word durable response. We can say disease control or but responder. Okay, so durable responder versus non-responder.
Mhm.
Uh, I think every clinical paper uses it differently, but what I like to do is anytime PR or CR, number one,
Mhm.
you don't need the 6 month criteria. For stable disease, you need 6 month, 24 week criteria. I will just call them responder. And whoever does not meet that criteria, we'll call them non-responder.
I'm sorry, it glitched and
Under non-responder. Because it's an oxymoron if you say okay, it's an oxymoron if you use the term durable responder and include patients who had first scan is CRPR, second scan is PD. There's no durability there, but it's a responder. And we want to call stable disease over 24 weeks responder. They are indeed durable response. So not by RECIST criteria. RECIST responder is defined as PRCR. But
Mhm.
for the sake of our own paper, we ourselves are defining, giving
Mhm.
new definition that's for the sake of our own analysis, we are calling responder. We're
Mhm.
going to take out the word durable because it's not really durable. So the responder for our definition is going to be PR/CR at any point
Mhm.
plus stable disease for at least 24 weeks. So that makes everything really clear.
Oh, okay. So would you not want me to categorize this into durable and non-durable? Would this not be something that I should go on for now? If we're taking out the word durable, or is
Yeah,
it just
response versus no response.
okay? Okay, so I'll try to. Okay, with this,
Responder, you can call disease control. You use that word here, right? Disease durable control, disease control.
that's a concept that Dr. Jiyoung she introduced that we might want to look into that too, but we didn't start the analysis yet.
Hmm. So there's a consensus for each disease control rate. There's a clinical benefit rate. Yes. So disease control rate is also ERPR as the over 24 weeks. That's and then the clinical benefit rate might be a little bit different.
Mhm.
Let's see. Cancer study, percentage of patients who achieved complete response, partial response, or had stable disease for 6 months. So I think let's just use this word because it's widely used. CBR, clinical benefit rate, or clinical benefit.
Okay. So, to summarize, we're gonna use clinical benefit rate and responder, non-responder, and disease control rate. Is that right?
Oh, so maybe. Okay, let me finalize it.
Yes.
So in our own definition, responder
Mhm.
will be someone who derives clinical benefit, as defined as CRPR plus SD at least 24 weeks.
Okay.
So that's the clinical benefit rate we can calculate.
Mhm.
Uh, it's not the RECIST responder definition, but it
Mhm.
is the clinical benefit rate definition. You derive benefit, we're going to call you responder.
Okay.
If you don't belong to that group, because if you use words like disease control or durable response,
Mhm.
then you're limiting CRPR to 24 weeks.
Yes.
But we don't want to do that. We want to be
Okay.
more broad.
Okay. Okay. Got it.
Let's do that. Yeah, that's
Okay.
settled.
So, okay. So I'll look into these data again with this new criteria. And I think so these questions are cleared up. But I do have one more question about the EDW. When we write the discontinuation date of the treatment, if the patient dies while he or she is on the treatment, do we write the death of the patient's date there, or do we leave it as a blank?
So when new patient dies, the last point of the date of contact, the death date, that's the that.
Yes.
So so you always need the last follow-up date,
Mm-hmm.
and that date should be last date of death, or if you don't know the exact date of death, um, any documented uh, date of last follow-up.
Mm-hmm.
And if you don't have the death date, you probably think patient is dead. Patient went to hospice and was lost. So if they went to hospice Don't stop there. Always go to Google, look for obituary, find that patient.
Mm,
Okay, that's kind of basic because we
So
don't want them to be last to follow. We want their date of death.
So if the person was on treatment but died, we would want the last follow-up date or the death date to be on the discontinuation date of treatment.
Yes,
Okay. So one more example that I want to ask.
but
If
that has to be within. Well, it doesn't make sense in the patient last chemo and the death is like 6 months apart. It's not the
Mm.
discontinuation, right? So it has to fall within that cycle of chemotherapy.
Okay. Okay.
But why do you need discontinuation?
I'm actually not very sure, but it was provided in this um template that Dr. Liam gave us. So if it's not needed, I will happily not record it.
I don't think it's needed because
Oh, but it was because of the drug toxicity.
all drug toxicity. That makes sense because in that case we might need a duration of treatment. Um,
Okay. But
because
then
in
if the,
toxicity,
oh yes, yes.
yeah, so I'm saying toxicity analysis, the more treatment you get, the higher the incidence of toxicity. So you have
Yes.
to account for the duration.
Okay. But if the person never developed a drug toxicity, do we still want the discontinuation date to be last followed or some other date?
So I don't think you need it because for PFS, you just need data progression.
Mhm.
And for get the PFS curve, it's
Mhm.
either data progression from the scan or
Mhm.
time of death.
Okay, got it.
And
Nice.
for OS, it's always death. And then, so I told all of you guys before, you don't read toward time of death. It's always the last follow-up date.
Yes, yes.
And then you have death 1 or 0, so that you know that's the death date.
Got it. And regarding the
Okay.
discontinuation date again, I'm sorry, but if a patient, for example, if a patient had the last dose on October 1st and the second dose was supposed to be on October 28th, and on the note it says he or she developed the toxicity at October 15 and says we will stop the therapy. What should I write as a discontinuation date? Should it be 15th of October or should it be 28th of October?
Yeah, last dose given.
Oh, so it should be like, it should be the first day of October.
The second dose was given or not given?
Not given.
Oh, yeah. So then the last dose, the first dose given.
Okay, because Dr. Liam and I was talking about this and we were kind of thinking that when we give the dose on October 1st, like the drug will work on until the second dose. So we were like, should we do it at the second dose date or like first date? But I guess this is
Yeah, that makes sense because then the duration of disease the duration of disease treatment would be 1 day. So that doesn't make sense. So I think yeah, let's go by the cycles, the next cycle, because the drug is going to work in the body.
oh,
And
okay.
then
So we
cycle
would
2, we decide not to give it on that day. So it makes sense to do cycle
okay.
2.
So we would do the planned next treatment day, but that didn't happen. Okay, I think my questions are clear. I just besides that, I just been keeping up with DICOM files that we received, and I've been talking with Dr. Jian about the criteria that what lesions to segment or what views to pick from the new DICOMs. And Dr. Liam and I shared the new 37 DICOMs that weren't shared before, like checked with thanks to Dr. Saley. And besides that, everything else is trivial, I think.
Sounds good. Thank you. Okay, Dr. Saley, any update from you? Good to see you from Irvine.
Uh-huh. It's getting chilly here, morning and night. Yeah. So last week I've been doing this the screening for the segmentation files 127. Yeah. So it's almost done. Actually, I've done my part in doing some of the Dr. Monica's part because she's sick, and hopefully it will be done by this week. And I'm waiting for the new DICOM files, the CD files to come for the segmenting. The 60, right? 60 files. Yeah,
Great,
that's all
great.
now. Mhm.
Thank you. Thank you for your hard work. Will, any update from you?
I think I'm like on the same stage as last week, EDW as usual. Plus the conversion of radiomics to pathomic slides and vice versa. We found like 10, actually 11 like duplicated slide numbers. So we're like backtracking the slides to make sure that each of the patient gets the right number of the slides. So it's on progress. And I think that's about it. Yesterday I picked up the slides from Dr. Alex. He wanted us to return it ASAP as we're done with like scanning and getting the images. So it was forwarded to Jessica on the same floor on the same team. She's expecting us to get it 2 weeks the latest, but it will go faster because like the workload on them like these days it's pretty low. So it will get done pretty soon. But yeah, that's
So 2
that
weeks waiting? 2
yeah, they
weeks?
told me like 2 weeks the latest,
Wow.
but she doubt it will like go that long.
And it's not done in Lee Cooper's lab. Where is it done?
So I
Scanning.
think it's like done from Dr. Cooper's like on the side of Dr. Cooper.
Okay.
We only received like 10 slides. It was pretty minimal, so I don't think it will take, longer time.
So Liam, please make sure to include Dr. Lee Cooper on any of the projects we use his scan. I feel like we've been forgetting him. And then he can give us input on it, like the tape draft, all that.
Okay.
Okay. And then let Dr. Alex know that, these are the timeline. The Lee Cooper's lab told us to wait, and as soon as they, scan it, we'll return. We'll give him like, reasonable expectation. Email him.
Sure.
Okay. Anything else, Will?
That's it on my side. Thank you.
Okay, thank you. Welcome, Brandon. I know your first time listening in. Liam, any updates that you answered? Yeah.
Yes.
Projects.
Everything else, I think I can discuss with you over the phone.
Yeah,
Later or in person. I do have an update on the slides. I just got an email saying that the 10 slides we sent to Dr. Cooper is it has been scanned.
oh, awesome.
Yeah, so I think it
That's
was like a small, it was only 10 slides, so I think they were able to get it done pretty quickly.
great. So yeah, just return it, and if you see out, let's maybe just talk about, what happened to the other patients that was,
Yes.
yeah, all that, yeah. And I don't know. Do what you can to express gratitude and whatever. Yeah. To bring coffee, whatever. I don't know why he's becoming so difficult to work with, but yeah. Okay.
Understood.
Okay. So we'll wrap up our meeting here. And I'll see you all next week. Thank you.
Thank you.
Thank you.